Our final speaker for the clinical portion is Dr. Lisa Ruppert. She specializes in rehabilitation. So continuing the theme, once pain is controlled, how do people get back to a normal life? How do they manage the symptoms? Not just pain, but everything else that you have to do in your daily life. So I'm sure many of you have been through this, and she can tell you what she can do to help.
I'd like to thank the Chordoma Foundation for having me and just the opportunity to speak with all of you. Kind of hearing your stories, the braces you've acquired, the assistive devices you have. I think a lot of you guys have tried to navigate the system. A little bit more about my background. I'm a physiatrist first, so my specialty in medicine is actually physical medicine and rehab. And then I wanted to be a spinal cord injury doctor and take care of patients like Superman. And I really thought that's what I was going to do. And so I went and did a residency in rehab and decided I was going to do a fellowship in spinal cord injury medicine. And one of the things that I noticed the entire time was I was spending a lot of time doing trauma. And I kept wondering, this can't be all the spinal cord involvement there is. It has to be coming from other places. I'm really hard-pressed to believe that these are the only patients we're taking care of. And really decided that my career was going to go in the direction of giving non-traumatic spinal cord involvement a voice, and particularly cancer-related, and really helping patients who don't necessarily know how to explain the symptoms they're experiencing or where should they turn to kind of have them addressed. So hopefully I can probably reiterate what a lot of you guys have self-discovered, but maybe even give you some other things that you can do or places to turn to. So I up front just want to tell you guys I have nothing to disclose. I'm still young, so maybe one day I will. So a little bit about where I started from in kind of preparing this talk, and I'm sure you guys all know a lot more about this than I do, but really understanding where chordomas are and what structures are in those places. So you all know these midline structures, skull base throughout the spine, sacrococcygeal, clivus, the mobile spine, particularly in the cervical area. Well, what does that really mean? And when I start thinking about it, well, first I want to know what it does, and what is it going to do to the bone? What is it going to do to your discs in those areas? What about the other soft tissue? Well, what else is kind of in those areas? And then I start thinking brain and spinal cord. And really when you're thinking about it, when you're talking about that clivus, you're talking about this brainstem area, and these little yellow projections in all what directions are cranial nerves. And they're the nerves that are going to help you with your vision, give you the sensation to your face, help you speak, help you swallow, help you chew, all those kind of things. Well, what happens if there is a tumor in that area? What about the treatments that you might have? How might those treatments, whereas they're good for your chordoma, how might that impact you later on? What about if we go into the area of the spine? We're talking about the sacrum, the lower portion, and I think Dr. Bolin kind of really brings out great points, and in terms of treatment and the radiations that we're doing for treatment, it's great. But what's in that area? We talk about that cauda equina, the horse's tail, the end of the spinal cord, and I think the one area most people see, well, it does innervate your bottom and your ability to feel a seat. Or things like that, your ability to understand your wiping. It goes down to your legs, and I think that's the one area most people see whether or not you're able to walk, how well you're walking. These same nerves, as we know, innervate our bowel, our bladder, and also help with sexual functioning. And I think it's one of the hardest things, even for physicians to understand, because we don't really see that innervation. It's not an outside area that we can see. And it really raises, and the frustration for me when people don't want to tell their physicians about it, we don't know unless you tell us. We can't see that your bowel and bladder are involved unless you're letting us know that. The other area, when we're talking up higher, the cervical spine has a very high rate of involvement. Well, what does that mean? We're talking very high up, or your spinal cord proper up in that area. We're talking about the nerve endings that are going to your arms, to your hands, really what you guys need for a lot of your ADLs. And then I actually perused your website, and I was wondering what it is, in my brain, these are the structures I think are involved. I understood areas that might be important, but what are you describing, and what does the Chordoma Foundation say are potential symptoms? So with clival involvement, there might be headaches, neck pain, vision impairments, altered sensation in terms of the face or abnormal movements, changes in speech, changes in voice quality, difficulty with swallowing. If we move into, the spine, whether it be in the sacrum or up in the cervical spine, again, there might be pain. There might be changes in spinal alignment. If we're talking about a tumor that's eating up bone, it's going to impact the support structures. And if we think of, that spinal column, it's that, suture armor protects the spinal cord, holds us up too. What happens if we're impacting that ability? What happens, in terms of surgical interventions or radiation? What is that doing to the alignment that you now have and that particular alignment that we were designed to have? What about sensory impairments? We were talking about nerve endings. You might see weakness depending on what part of the spine we're talking about. It might impair just your arms and your legs or just your legs. Bowel and bladder dysfunction and sexual dysfunction. So where do I come in? I think sometimes rehab is this little known secret, and a lot of people know it. We have physical and occupational therapists, but we do also have a good component of physicians who play a role and who want to help. And overall, I think rehab, really, we aim to relieve symptoms, improve quality of life, enhance functional independence, and prevent further complications. Really, we want to get you guys back to what you need to be doing, you want to be doing, and we want to make those amazing oncologists and surgeons and radiation oncologists who are treating you, we want to make their outcomes even better, and we want to help them help you. And that's really how I look at it. So I know I mentioned a lot of symptoms, and I know I have 15 minutes, so we're going to touch on some of them. And I want you to know that by no means, if it's not on this list, it doesn't mean it's not important, but just some of the ones to highlight. And I think Dr. Putnaya did a great job talking about pain. It is something that is very important, and oftentimes in rehab, there are other modalities aside from just pain medications that we may be able to help you out with or help you to understand where that pain is coming from. So I just did want to mention it. Bowel and bladder dysfunction, I think, is huge, and I figured since we know it's underreported, we're going to talk about it. Sexual dysfunction. I have a lot of people who do come to speak to me about it, and I always joke I'm like the cool person who did it first, so maybe I know all the answers, and maybe I don't. But I think it's something important, and it's something that I'm sure is on your mind. I know in the world of trauma, they've done studies on this, and they've actually asked young men who have traumatic spinal cord injury, what's the number one thing you want? And they found that overall, I want to know if I can have sex and how you're going to help me have it. It's only number 2 in individuals who have upper extremity involvement, because number 1 for them, they want hand function, and then they want to have sex. And so it's important, and they're willing to speak about it, and I think that, other groups might be a little bit more shy, and I think even as physicians, a lot of times we're shy, so we really just hope you don't bring it up. But I want to bring it up to you today. And then I know there's a lot of, clival involvement, and I think, in terms of not only speech, but swallowing is huge, and it's huge for lots of reasons. Obviously, I like to eat, and I like to eat foods of different consistencies, and I'm sure you all do too, but nutrition is essential, and nutrition is essential during treatments, so if you're not able to swallow, then it's something we need to really make sure we're addressing. So when we talk about bladder dysfunction, I think every commercial on TV tells everyone, I gotta go now, and there's all these wonderful medicines for when you gotta go now. But let me just tell you, not all having to go now is from the same reason. And I think that's one of the hard parts is really, why do I have bladder dysfunction? And society is starting to say it's okay. There's so many Depends commercials, and there's a medication for everything. But at the end of the day, we really need to understand why. Bladder dysfunction from my neck was involved is a lot different than bladder dysfunction because my sacrum was involved. The nerve endings are going to be a lot different. I think you guys might notice, when you're talking about the more of the cervical involvement, you have a lot of the tone and the spasms that occur. Well, that means that your bowel and bladder are probably doing the same thing. If you're more lower down and you start to see that weakness and you're a little bit more flaccid, guess what? So is your bladder, and so is your pelvic floor. So really where we come in, and we can come in as physiatrists, is try to help you understand where it's coming from. Use what we're seeing on your physical exam of your arms and your legs and your sensation and your reflexes to kind of point us in a good direction. We can institute voiding diaries. I say 3 days, 2 weekdays, 1 weekend day, because your weekend day is always different. Just record. How often are you going? Do you leak in between going? Do you feel like you go for a really long time, counting seconds? Or is it really short? Do you feel like you've gotten it all out? Are you not sure? Do you stand up and you're like, oh wait, I gotta sit back down again? Or do you get up and the minute you go, you're looking for the next bathroom? It tells us a lot, and voiding diaries tell me in real life what exactly it is that you're doing. I can actually have you void in my office and see how much you were able to empty, and then scan your bladder and really get a good sense of what's left behind. We can also do urodynamic studies. Why? Because there's things we can do to help you with continence. We can help you with medications. We can help you with dietary modifications. We can prescribe therapies for this using catheters. We can do things, just simple techniques to help you push more out. We can use reflexes that you might have. Same thing with the bowel. Understanding, using my physical exam. Why aren't you emptying? Are you not emptying because of medications? Are you not emptying because there's nerve involvement? Do I need to bulk up your stool? Do I need to make it softer? I really try to take a lot of time to understand this. All the same kind of things, using exams, using different studies to truly try to understand where this is coming from. It's not all medication related, so please don't think that. There might be another reason it's happening. And the goal, you should have a bowel program. You should not be thinking about having bowel movements when you want to go out, when you want to have dinner with family, you want to go to a party. We can help you with that, adjusting diet, making sure you're getting enough fluid, using different kind of medications to soften or make it a little bit more firm, help you empty from down below, help you get it done so it's out of your way. Sexual functioning, again, I do encourage you guys to bring it up, whether it be from just self-esteem issues, body images, your treatments. Is it a mobility problem? Do you have weakness? Are you able to have erections? Are you not? We're really good at sorting through this and getting to the bottom of it and helping you, because it's a part of your relationships. It's a part of your daily function. So it's not something that you guys should be fearful of, and it is something that we really can help you with. I do want to touch about dysphagia. I think that it is important for us to understand. I know we just moved all the way on up to cranial nerves, but we can help you. Please report it. Please let us know. We can do a lot in terms of understanding. Is it sensory? Is it weakness kind of thing? Is it in the mouth? Is it below the mouth, kind of more in the esophagus area? There's studies we can do to help us understand it. We have great teams of speech therapists who really work on the oral motor skills, different techniques to help you swallow. We can help you in terms of different food consistencies so that you're able to, enjoy the food you want to be enjoying. We also do play a role, not only in the idea of, relieving symptoms, but we play a role in preventing complications that might occur. When they are doing surgeries, we're changing what your spine alignment is. We're doing things, just the tumor itself, that might eat away at bone, that might impair that as well. Looking at skin breakdown, again, when we deal with dysphagia, we look at aspiration. So we can do things in terms of physical exams using imaging to understand your alignment, kind of help you, keep you nice and upright, keep you comfortable, something we can do for pain. Making sure we're using our exercises to keep you strong. Fractures not only in the spine, we want to make sure that you're not falling. I think there's some great AFOs that are floating around to different assistive devices. We can help you figure out what's the best assistive device for you, keep you mobile, keep you independent, and not only with that, just using our physical and occupational therapies. I think it's important to note that when we're doing the therapies, we're really trying to help in terms of giving you precautions, taking precautions into account. So we're keeping you safe, so don't be fearful when therapies are recommended. They do play a great role. Skin breakdown is huge. I want everyone to shift their weight because you guys have all been sitting still too long. It's very important every 15 to 20 minutes to kind of shift what you're doing so that you don't get skin breakdown. I want to keep you continent. I want to make sure your nutrition is good so that you don't get skin breakdown and don't get into trouble with it. Building on the whole idea of dysphagia is aspiration. All those same things, we're going to address it more from the swallowing standpoint, make sure we're keeping you safe. We have a good plan in place for you so we can play a role. We want to keep you out of the hospital as best as we can. Again, like I said, the speech therapist. All of the things that I'm doing is really to enhance your functional independence. I want to understand your neurological status, whether it be cranial nerve or weakness down below. What does that mean? What does that mean in terms of your function? Because that's the end of the day, we're functional medicine. How do we use our therapists to enhance what you do have, to support what you don't have? How can we use, not only our physical and occupational therapists, speech therapists, vision therapy, help you see what you want to be seeing, what you're reading, seeing my slides. There's a lot of things that we can do for you. We oftentimes will try to assess with orthotics, whether it be from the spine to help you with posture, getting used to new alignment, whether it be in your arms or your legs. We're very good at that. What kind of assistive device? Do you do better with a cane? Do you do better with a walker? Maybe I think you should do better with a walker, but you can't figure out how to navigate it. What's the safest thing for you to keep you independent? My overall goal for all of these things is to improve your quality of life, because at the end of the day, it is hugely important to you, I know. I think it's great that our oncologists are doing what they're doing, our surgeons, our radiation oncologists, and the hope is that as they keep their treatments get better, we keep you alive longer. Well, you want to get back to your regularly scheduled life, and that's really what rehab and what we want to do is going to help you with. Not only can we do it with our therapies and things like that, but kind of helping you identify community resources. I think the Chordoma Foundation is a great one, but we work a lot with the Lighthouse, the Coalition for the Blind, paraplegic societies, different spinal cord societies. All of them, you guys would fit into those molds, and I think helping you explore all the different options you have is going to be important. I do just want to touch on rehab is safe, so please don't be fearful. We definitely understand that you guys are busy with treatment, but do consider us part of it. We do take into account your oncological status, your medical status. We do understand we're a moving target, and that's okay, because as you move, so do we, and our goals always change to make sure that we're meeting the needs that you do have right now. So it is something that I do think kind of plays very well into what everyone else is doing for you here. And with that, I say thank you.